This is basically part 2. Initially, I did think when I was preparing these things that should I just go in one go, but I thought it'll be too much of me at the same time, so I thought I'll give it a small gap. So basically, we just discussed about hypertrophic non-union. I don't think I'm going to tell you anything new after the morning. All the important things, X-rays, everything has been shown to you. But since I prepared the talk, I might as well give it to you. Okay, so this is a comminuted pilon fracture I had. And I think I did a nice job, made it straight, corrected it, but it got infected. And then what happens? As happens, you go in, take the screws out, and then he's painful non-union, he said, do something. And so this is a good case. So what I did was I put in a frame, straightened out, didn't open it as we do, and it healed, right? That's the clinical picture. So yeah, seems to work well. And if you look at the systematic review on the monofocal distraction, because that's what we do normally. So non-unions, which are non-infected or the infection is quiescent, is not active infection. You can just do a monofocal distraction and seems to work well. In our clinical practice, there's a systematic review and it's actually quite good outcome. And it's basically on simple thing, the Parent's theory, which we all know about. And what we tend to practice is the hypertrophic, we distract because high strain, and atrophic, we tend to compress and optimize the strain. So what we use, X-fix. X-fix we feel is the best because it's got number of advantages, very versatile, works very well, and we can manipulate, is the only device which we can manipulate the mechanics. It has got own problems, patients don't like it, and pin sites get a lot of infections in that. So this is another case. This patient had an MTPJ fusion, and what happened is that they took the bone graft from the tibia, and it fractured, and it didn't heal in plaster. So when it came, and again, all you do is just gradual distraction, do it very slowly, right? Don't open the non-union site. In fact, this one almost healed before I finished correction. There's the final picture. If you look at it, there's still slight varus in it. It's not fully corrected because it healed and it won't correct. And what you need to do is, in these things, you need to just, all you're doing is optimizing all we're hearing all morning. Is basically when you increase the tension, increase the stiffness and decrease the motion. And ultimately, it's optimizing the mechanics and the strain in the non-union. That's what it happens. And it heals well with most of us. Not all of them heal, but most of them. So the take-home message in a hypertrophic non-union is you distract it slowly, and whatever healing is there, exploit that. Don't try to break it. You do it quickly, it will break. And therefore, do it slowly, let it gradually distract, let's have a beautiful tension stress effect, and let this fibrous tissue convert into bone. That's what you need to do. Then, if you look at it, there were some studies about the MSCs, and I did tell you, we spoke about this before as well. If you look at the MSC counts, they are similar. And there seems to, from the non-union side, this is a hypertrophic non-union, where they took some cells, and they looked at it, and they found that the osteogenic, chondrogenic, and adipogenic capacity is exactly the same as what you get from the healthy volunteers' bone marrow. Right? So again, I'm trying to same thing a number of times, but basically what I'm saying again, the non-union site is quite capable of healing either atrophic or hypertrophic. And again, this is going to be a repeat of the slide. And if you look at it, they all heal and heal well. So I'm not going to say that. So now, what device we're going to use? To be honest, it really doesn't matter what device you use, right? You can do a combination of things, right? You can use more than one implant, internal, external, or two internal devices we use quite regularly. Combination techniques are useful. And what they do is, as long as, and again, it's very hard to say how many screws and what to put in what way, because there is no measure, there's no gauge what to do. And sometimes it comes with experience, you think it's okay. Sometimes you're right. Well, most of the times I think we manage it reasonably well. Sometimes we are wrong. And because since we don't have any gauge or any measurement, we just do it by the sense, I think this should be fine, that kind of thing. So this is a this is a young lady. He had a nailing done in, I think, Eastern Europe, I think, Romania, I think. And she had a non-union, and she's finding it difficult to walk, and there's a painful, and it's not working. And I think she's been waiting list for a while, so I put her on a waiting list, and I thought, this is what I do for all non-unions. If they're not painful or they can manage, I put on a waiting list, on the routine waiting list. Because by the time their turn comes in, almost all of them heal. So you don't have to operate. And they are always happy they're on the waiting list, right? But sometimes when they're painful, and she didn't heal. She was for a while on the waiting list, didn't heal. And then, so what we did was we thought we need to do some limited procedure. And we had some discussion. And I think Alex did a study about the stiffness by re-nailing and putting local screws, and this seems to be similar. So all we did was we did a CT and looked at it where we need to work. And then on the CT, we identified where we're going to do and put these are the 2 screws we're going to put in, right? And then we took her to theater and put 2 screws. And if you look at it, these are the post-op pictures. And if you look at it, from the pre-op to post-op, this is 2 weeks post-op. Her pain is settled. She has no pain. She had a pain on the non-union side. That is settled. She has pain in the foot. That's a different thing, I think. But the non-union side pain is gone. It's compressed. It's looking fine, right? A circular frame, what it does is it's very good in almost everything apart from shear. And in shear, very few things work. You need to balance the forces in a shear. And this is an example of a non-union. So all you need to do is put 2 screws, put in a neutralization frame, and hold it. Now, you can't nail this thing, right? Well, you can. It's going to be hard work. But frame is easier. And all you need is, the frame is a neutralization device here. And this is important that you optimize the local mechanics, and then you can use whatever device. You can use a plate here. It really doesn't matter. So the principles is that if you have an implant, try to utilize, if you can, like if there's a nail, do something, screws or a small plate, so you don't have to re-nail, because it's a much smaller procedure. Percutaneous works well. If there's a nail, then sometimes it's easy. You put a couple of screws, like the example I shown, or you can put a small plate. That works well. If you're going to plate, then sometimes you need to look at it, is single plate enough? What is the problem? And circular frame, because it's so brilliant, I won't talk about it, right? So this is an example. An elderly gentleman had a periprosthetic fracture and went to theater. If you look at it, I think the fracture was extending much more than shown on initial X-ray. And there's a lot of wires and things, and it happened. So it's looking all right, actually. There was no long leg film, so we don't know what the mechanics were. And about 7 months later, he reported with the sudden increase in pain. Now, there's a bone is trying to heal, right? Clearly, there's a problem. And I think the problem here is that if you look at it, as this started healing here, and then it became more or less like a transverse non-union. So your strain changed from a low strain to very high strain, and this plate probably was not optimum for that. So if you can predict it, then all you need to do is put in a couple of screws here, maybe another screw there, and that probably would have healed without breaking the plate. But the thing is, you don't see it, and sometimes you don't know about it. And he only reported, he was seen in the routine fracture clinic, and then he came around with the broken plate. So what you do is you go back in. So we went in, made sure the alignment is fine. We did not open the non-union side. In a sense, we didn't debride it. We had to open the non-union side because you have to take the plate out. But we didn't try to clean it or do anything. No bone grafting. Put in a plate, mechanics, and it's looking fine. And this is the picture in 12 weeks, pain-free, almost healed, and it's doing fine. So I think what we need to do is we need to optimize things to help, and actually most of the time it actually works pretty well. So how I started? When I started, I used to exercise everything, bone grafting, segmental excision, all kind of things I used to do. And then I realized probably it's not that much necessary. And I stopped doing general excision. I just do a little bit because I thought that is important because I need to freshen the ends. And then I understood a little bit better. And now the current practice is I do not routinely open non-union site, very limited bone grafting in my practice. And I think this is how I learned and understood, and I think I improved. And at the time, we need to look at it that assessment of problem is a major issue. Implant is almost secondary. Implant is there to help you reach your goal. Assessment and optimizing of the problem is actually the more important thing. Whatever implant you use, it is fine as long as you balance the problem. And I give you the simple example. I don't know, you probably wouldn't have read it. Bigelow, who described the hip relocation technique. So the story is, and it's a published article actually, I think 1837 in American Journal of whatever it was, I can't remember. And he was an A&E doctor, Bigelow. And what he used to do, whenever hip dislocation come, he'll reduce it and send it to surgery. And the head of the surgery got really upset. He said, I'm the surgeon, I'm the boss, you will not do it, it's my job. He said, fine. So he dislocated. Well, I think you could do it in those days. He dislocated the hip and said, all yours. And the head of the department couldn't relocate it and called him back. And he relocated again. And if you read that article, all it is was he reversing the principles, reversing the process, and how we do the dislocation, relocation of humeral head or hip. What we're doing is just balancing the problem. We're going through, understanding what is the problem, and reversing the problem. That is what you're doing, and that's what non-union is. So to summarize, is implant is stable, then I think what you need to do, you can do close treatment without any problems. All you need to is optimize the local mechanical environment. If it is fractured, then you might have to do something, because sometimes you have to remove the implant. You can remove the half plate, you don't have to remove the full plate, right? And then whichever way you do, but stability, but alignment is very critical. There's one thing everybody misses. Alignment is very critical in all this, because the forces how it go through, especially in femur, are critical. And the combination of implant is perfectly acceptable thing, and you can easily do it on day-to-day basis, works well. Thank you very much.